Good afternoon. My name is Marina Chen. I am the head of program of Brain Challenges program, head of development facilities and transformative technology in the research, innovation, and global engagement in on this. So I'm very glad we're here to chair this section. And this afternoon we have two parts. The first part will be the talks, and the second part will be more interactive. And the first part will have the talks. The first one is Professor Kathy Skova and Constance Wheeler. Welcome.
Well, thank you for the introduction, Marina, and it's great to chair this dual session where we will be firstly celebrating the results from the GANSTA project and having a couple other colleagues who are working in the field of antibiotic resistance. And then we will celebrate the Grand Challenges exhibition with a few more projects. And we will kind of phrase it as seeing how the bad bugs we're trying to combat, not to make us ill and combat antibiotic resistance, how they can be also supplemented by the good bugs. And the good bugs can make, for example, cheeses. So look forward to some of the good bug session of this session number 2. So over to GANSTA. So GANSTA stands for Persuasive Gamified Antibiotic Stewardship Decision Support App, which helps surgeons to make the right decisions about prescription of antibiotics for elective surgery at the point of care. So for those of you who are not involved in antibiotic resistance, so this is one of the major global issue where bacteria are naturally becoming resistant to antibiotics. So we are getting to the phase where many bacteria basically are resisting, and we are not able to treat the diseases the way we are expecting to. So this is a global issue, and as you can see, those numbers, they are quite scary. So it is expected by WHO that the death caused by antibiotic resistance may reach 10 million people and will cost the global economy 66 trillion pounds. So imagine, we're going to go back to the pre-penicillin times, and when people were dying of minor infections. So it's really something to be aware of, and it's at a similar scale as global warming, people are aware of, but AMR still is something which has to get to this level of recognition. So many things can be done by the global community to slow down the resistance process. And one of them is quite important, is overprescribing. So why are we overprescribing? Well, many reasons. So one of the NHS project which I was involved in 15 years ago back at City University called Bugs on the Web was educating public in the UK not to want antibiotics from their GP when they had a little cough and cold. Because the GP didn't have the time to explain the whole complexity of resistance and just prescribe out of the pressure to sort out the patients in the 6 or 7 minutes they have for the consultation. So it could be pressure from patients. It, of course, could be lack of awareness and stewardship issues on the side of the professionals. And it also could be prescription of wrong antibiotics, or, as we see in the project in Nigeria, giving antibiotics for the right cause or for a long duration, which is not necessary. So we worked at 2 locations in Nigeria, in Lagos, where we worked in a Lagos University Teaching Hospital and Lagos State University Teaching Hospital. And we also had a third partner, Study State in the Delta, in the south of Nigeria, where we worked in the Madoka University Teaching Hospital. And now we are piloting in the Whittington in the NHS to show how this intervention could be helpful in the low income as well as high income settings. These are our colleagues from GANSTA Nigeria, who unfortunately couldn't be with us today, but have been instrumental in making things happen on the ground in those hospitals in Nigeria. So if you're wondering how a hospital in Nigeria looks like, so these are examples of the hospitals where we were. So this is the 2 Lagos hospitals, and this one is in the Delta. So the conditions are really, it's a low-income country with state-funded hospitals, so very, very low resources. So you have things like, power cuts in the middle of the hospital in the middle of the day, when suddenly the lights go off, and People have to continue to be treated somehow. People have generators when they try to keep the drugs, if they can afford generators. So really kind of it's inspirational to see how the doctors and nurses are operating in those conditions to make patients well. So why is it an issue? You know, when we know what we should prescribe, we have guidelines. Why is it an issue that there is overprescribing or prescribing for longer than advised duration? So normally the surgeon meets with the dependent patient. So if you're going for elective surgery, you will have a meeting with your surgeon, discuss the surgery, and a decision will be made whether the surgery requires or doesn't require prescription of antibiotics. So procedures could be divided into low risk and high risk. The low risk ones are very unlikely that the patient will develop an infection. So these are not recommended to be using antibiotics for, and the high risk are supposed to be using antibiotics for. So the decision is made before the operation, then the operation happens, and again, things can go wrong, but something can happen. So the prescription has to be changed throughout the operation. In some cases, it is exceptional, but it may happen. And then after the procedure, the decision is again recorded in the electronic patient record to actually reflect what genuinely happened in the operation. So all these decisions sound straightforward, but they not always are. There's always a space for a human error, lack of knowledge, and wrong decisions to take place. So the project has got 4 parts. So we started with exploring the barriers, which will be presented in the second talk by a colleague of mine, Caroline Wood, who is the former deputy and manager of dPHE. Then we developed the actual app. We developed the back end, the decision support tree, and we have piloted it through coding development and co-authoring with Nigerian surgeons. And then we have applied it in Nigeria in different hospitals and collecting the results. It will be presented by a colleague of mine, Suzanne, who will be discussing how the intervention was effective in delivering the desirable change. So the app is actually quite simple, because you want someone who is a business surgeon to actually use the app while they're performing their visit job. So they add a patient, they decide if the procedure is low and high risk. And as you can see, you can get a feedback. So in order to generate the actual data about the change of the decision, you record the initial decision, and the feedback is either telling the surgeon, yes, this is all right, this is in compliance, or no, this is not recommended. You may reconsider your decision. This is what WHO or Stanford guidelines would be recommending in this situation. And then you can, the surgeon decides if any procedure is required, which one, and for how long. And again, gets a feedback to be able to know if the decision is or isn't in compliance. So this is how the data looks like. And this is an example of the feedback, negative and positive. So you can tell from the color coding, it's visually inspiring. You can also say it's a dog. And why would you think a dog would be a symbol of a mentor? But our local colleagues in Nigeria have chosen out of many characters, human and animal and object, the dog would be their mentor, which they associate with a symbol of kind of wisdom. Again, the decision support can also collect the decision where there's a reason for not complying with the guidelines, which of course the surgeons may have. So we record the reasons for not complying. And if you're wondering how the app works in the back end, there is a complex decision tree which collects the information about the patient, if the patient is high or low risk, what is being prescribed for what infection, and then it will highlight if the decision is or isn't compliant. We also have built-in gamification. So the surgeons can collect some awards. They can compete for the first patient, for the 10th patient. They can compete among themselves. So they can get some feedback from the awards to keep them using the app for longer. And as I mentioned, we have demonstrated a major behavior change in terms of using the app after the decision was made, which will be discussed in detail by Susanna in the first talk.
My name is Kwanza. I'm member of that section. So here we got some feedback from our personnel in Nigeria. One said that the app was very easy to use and it was helpful for them to prescribe the antibiotic. And also one said about they love to continue to use it, and it's also make them confidence to not going beyond on prescription. And also one said that it requires a lot of speed internet service to access the app, and internet needs to be very good. And today we are going to localize the Gaza app to the UK setting with the first pilot on medical trust using microguide. And here we have Adrian as project lead at Medical. She's consultant pharmacist in antimicrobial strategic and professional leadership on AMS. And she will be joining us at 6 p.m. at the AMR panel. And finally, congratulations for the Gaza team for the awards. The first one, Patty and team won completely in IT Excellence Award Innovator of the Year 2019. And second one, Caroline Wood and Gaza Project team as the runner-up, Best Partnership on the DPH 2019 Conference Innovation Awards. And then the third one, Gaza team won the UK IT Awards runner-up in the category Best Healthcare Project the year 2020. And this is the Gaza team. And thank you for your kind attention.
Thank you. So we have a few minutes for questions.
Can you talk about why it's important to integrate this? Why this group and
So I would say 2 points about this. I think the doctors are really overwhelmed by loads of decision support apps, and then a lot of them are not working or too complicated. So we try to make it as simple as possible to actually make them use it. So that was one kind of design reason. The second design reason was the role of the mentor is a certain character which is used in persuasive technology to communicate certain message to the player, in this case the surgeon. And there was lots of discussions, and one focus group just dedicated to the development of the mentor, what they would associate with kind of the right feedback to make them change the decision at the point of care, which seemed to have worked, and the doc was the successful winner of the mentor. In terms of the awards, it's a very good question. Some people are competitive and they kind of like to get awards and win and get in the top of the scoring tables. Some people just didn't care about it. They just kind of wanted to do a good job and prescribe better antibiotics. So we complemented these particular awards with a WhatsApp kind of awards. We have WhatsApp group. People were getting like some direct discussions about who has been successful in this week, or which hospital has been more.
is behavior okay? How do you think?
More active in this week. So combination of having the human touch through the WhatsApp group and the technology of games were essential. The technical challenges were not actually major. We have developed loads of apps, so we just follow the usual process, got loads of focus through iterative process, and make sure the surgeons are on board, make sure they will actually use it. They help part of the process. I went over to Lagos to have a focus group with them, on site. So this was something where I think there was a successful software development process in place with all these kind of gamified and persuasion game points. The challenge comes in making them use it. And we wanted them to use it for 6 months to be recording the decisions they've been making throughout their kind of real life surgery. So getting people on board was essential to get the local collaborators on the ground who encourage people to start using it, explain the project, and then kind of we were giving them little awards throughout the actual 6 month period to make sure they continue using it and record a number of data we wanted to. So I think the kind of continuation of the use has been the major challenge. So one was like the persuasive techniques on the people on the ground. So the Professor Ashada Ogunjula, who is the PI, she's a very senior, she's a dean of the faculty, so she works in the hospital. So obviously her team had a very high kind of reputation and kudos. So they tried to get people on board and they were very successful. So without them, we would not be able to succeed from the UK. They had to be led by the local experts. Also, a lot of the experts felt actually it's exciting to be involved in a big technology project. They obviously contribute to generating data. They've got all sorts of publications we generate. So it was a very equitable kind of project in terms of their perspective as well. And also small things like giving people some airtime and like data bundles so they can use it when they were actually recording decisions, but also beyond that were also helpful. Big part at the end they had in Nigeria, which also kind of celebrating the success of the project and their commitment to it was also a good selling point and engagement component.
So the big question, how whether that is the data is accessible for the public or it's for any particular group of people?
So the data are collected, they're private, so they're private for the project because we're collecting patients' data. So it is not available for public or for anyone. However, the publications, of course, are available. And if anyone wants to read the papers, then that's more than welcome to do so.
Thank you. This is a question.
Thanks for doing this. I was wondering, there's scope to expand it to other settings where it's even a really good surgery that they looking to expand it further, not just this environmental, right?
Absolutely. So the reason we have chosen elective surgery was because the decision is quite simple in kind of medical terms. So the decision tree you've seen is only like 5 layers and it's quite simple. So we would be excited to take it out of surgery into different settings. We also would be looking into having like a multiplayer game because sometimes the team who makes the decision, it could be the pharmacist who actually is deciding the role in the team, not necessarily the surgeon the way it is here. So yes, absolutely, we would like to. So we can talk afterwards.
Yes.
About the behavior change based on expansion, the same projects. Welcome.
Thanks, Alicia. Good afternoon, everyone. My name is Dr. Caroline Wood, and I'm going to be taking you through in more detail how we used theoretical frameworks from the field of behavioural science to underpin the design of the GANSTA app. So here's Patty's slide from the previous talk, taking you through our methodology and our approach for the project. So firstly, in addition to referring to the existing academic literature as to some of the potential barriers to guideline compliant prescribing, we kicked off the project by carrying out an online survey and 4 focus groups to help us further understand the context of the challenge and specifically explore the barriers to compliant prescribing direct from health professionals themselves. Now, this rich data informs the technical development of the GAST app, including the integration of evidence-based guidelines. It guided the overall design and interface of the app, as well as a character mentor that surgeons identified they'd be most comfortable taking advice from. Now, the final stage of the project involved a pilot testing phase of the app, where we invited surgeons across 3 hospital sites to use the app for real-time data collection when making prescriptions for surgical antibiotics. And we triangulated data on barriers we identified through the survey and through the focus groups with reasons professionals gave for when they went against guidelines in the app and made a non-compliant decision. It's these 2 points here that I'm going to talk you through now. So what do we already know about the barriers that might be occurring in Nigeria specifically? Well, looking to the literature, we could already see a number of reported barriers standing in the way of compliant prescribing. And Patty alluded to a couple of these earlier, including the practical and resource restraints, meaning that prescriptions can change as patients are handed from one part of the medical team to the next, and also meaning that prescriptions can often, for these reasons, be incomplete and maybe inconsistent as well. We can also see evidence of strong cultural norms existing among surgeons. You can see the study at the bottom by Kadia, finding that among surgeons with duty symptoms heavily influenced by more senior staff in the department. So with the online survey, the link was distributed via email and via the project WhatsApp groups we set up to communicate with participants. And a total of 66 junior and senior residents provided us with their thoughts. We used a behavioural framework called the theoretical domains framework to design the 30-item survey, and in total we tapped 13 different behavioural domains to try and understand the key barriers that stand in the way of surgeons complying with prescribing guidelines. So just a bit more about the theoretical domains framework, or TDF for short. It's a framework designed from a synthesis of multiple behaviour change theories, enabling it to provide a detailed analysis of what might be enabling or preventing a behaviour from happening. It's been used to analyse a wide range of healthcare-related behaviours, including prescribing. The participants were asked to rate their agreement or disagreement with items tapping, for example, the practical domain of skills, with questions such as, I have been trained how to administer the antibiotics according to the guidelines. Another domain such as professional role and identity. So, for example, most people whose opinion I value approve of following the guidelines. Onto the focus groups. In total, we carried out 4 focus groups to delve deeper into the insights we found following the survey. And each group lasted for approximately 90 minutes and was facilitated by our partners in Nigeria at 2 of the hospital sites. And we structured the focus group questions using another framework, the COMBI, model of behaviour change, and used the TDF, the theoretical domains framework, to guide probing questions where we have found that there were particular areas of interest, such as specific barriers or complexities of the practice that we just wanted to know a little bit more about. And in total, we gained thoughts from 28 of the junior and senior residents. Just a little bit more about the COMBI model. It provided us a very, very simple framework for understanding facilitators and barriers that might be in existence. So based on the premise that someone must have the capability, the opportunity and the motivation to enact a given behaviour, we asked our groups to discuss questions such as how easy guidelines were to access and to implement in practice, but also their thoughts on what the immediate and eventual impact of not following the guidelines would be. You can see our lovely focus group participants here at the top. And just to give you a little flavour of the findings, what we found from the 2 different groups of data collection was really interesting. Now, all of the group were familiar with the guidelines and most were confident they could, at least from a knowledge point of view, use them in practice to guide their prescribing decisions. Good access to guidelines was a different matter. Some said there were only a couple of hard copies of the guidelines available in the hospital, somewhere, which made them very difficult to refer to easily, which meant that most sought information online, which in reality could take just as long to find exactly what they wanted to. The beliefs about the consequences of what would happen with and without compliant prescribing was one of the key themes arising from both with participants explaining that the environment was their rationale for prolonging their antibiotic prescription beyond the recommended 24 hours as standard, as recommended by the guidelines. Some said that their prescribing decisions were limited by the surgical environment in Nigeria as well. We also saw evidence of what we've seen come through from the literature about cultural norms and junior staff following more senior staff's lead. So instead of referring to the latest guidelines, you've got a culture of senior staff passing on tips as to what had generally worked for them in terms of antibiotics and dosage and duration as well. And there was also a suggestion that there was a lack of overarching policy, and therefore any repercussions that if they chose not to comply with the guidelines, there wouldn't be any consequences as such from more senior staff or from policy governance. And this influenced their behaviour of whether to comply or not with the guidelines. On a much broader level, all of the group believed that guidelines were key to slowing the spread of AMR, but expressed a reluctance to apply them to the Nigerian setting unless there was good evidence, supported by research in the Nigerian context, that this would lead to good outcomes. Beliefs about patient behaviour also drove some of the opinion, prescribing antibiotics as a preventative through worry that patients wouldn't care sufficiently for their wounds post-surgery at home, have access to a local clinic that would do this for them, or concern that a patient's home environment was an infection risk. And all of these were popular and regular discussion points throughout the focus groups. Nigeria has a privatised insurance model where healthcare is considered a product or a service. And so surgeons said that there was a certain amount of pressure to prescribe from patients. And also, if they weren't prescribing at the hospital for patients to collect at the hospital pharmacy, there was the idea that patients, or the worry that patients would get antibiotics elsewhere from perhaps unregulated sources and therefore risk their health. So to wrap up from these findings, our work with the teams in Nigeria sheds a lot of light on barriers and facilitators to compliant prescribing and gave us a much better idea of what's going on in that context. And taking a behavioural approach enabled us to identify the key points in the prescribing journey where the GANSA app could make guidance easier to implement at the point of care. So we moved into the development phases with 4 takeaways in our minds. Firstly, enabling surgeons to add reasons for not complying with the guidelines and carry on that form of data collection and build that into the app would enable us to see how guidance needed to be shaped to increase compliance in the Nigerian context. The unique decision feedback within the GANSA app would aid surgeons' learning related to compliant prescribing. And 3, that surgeons, as well as other professionals, such as pharmacists, could value having an easy-to-access decision support system that they could quite literally reach into their pocket to refer to. And finally, that our work would open up much wider conversations in Nigeria relating to infection control policy and the potential risk presented by that very unique clinical environment. So just a thanks to our funders and to our wonderful colleagues in Nigeria across the 3 hospital sites, all the surgeons, all the pharmacists and the residents who contributed their time and all of their very interesting discussion points to this piece of work. It really wouldn't have been doable without any of these people, so thank you. A final note, if there's any further information about the application of a behaviour change approach to the GASDA project, it can be found in this paper on screen now. Thank you for listening and happy to answer any questions that you might have.
Any questions? I didn't realize that antibiotics is such a kind of complex behavior issues, because you go to the doctor and you just have some prescription, and in different contexts it's quite different situation, different practices.
Absolutely, yes. There's a lot of different actors and a lot of key behaviours that need to happen as part of that pathway, especially when there's guidelines involved. And as you saw from the data, there's a lot of cultural and social norms happening in that space as well, like the expectations of patients that they should receive antibiotics from the service. And actually, no, not in all certain circumstances. So yeah, really interesting space.
Qualitatively in the needs amongst young residents and doctors, it seems to me that they would represent different points along the education and capacity pipeline.
Yes, you are absolutely right. I haven't mentioned it here, but it's mentioned in more detail in the paper, so I recommend giving that a read in a coffee break. But definitely, so we saw that typically the junior, not all, but the junior residents were more interested and open to the aspect of training and to receiving feedback on their prescriptions. We saw that obviously the cultural norms piece I've spoken a little bit to, but they're tend to be more influenced by the senior staff, so less likely to go against make non-compliant decisions within the Gazette app. Trying to think of the other differences we saw. The type of antibiotics, there's also a difference there. So the more senior consultant residents were likely to prescribe more broad spectrum. So again, that relates to the guidelines, the confidence that this has worked before as a key attitude. So we're going to go with that versus the more junior opinions of the guidance says this, so I'm going to stick with this specific antibiotic. So yes, a lot of differences, and it was really interesting to see those come through in the data.
Thank you so much.
Any other questions? Is there any feedback loop between the doctors and patients in terms of the use of antibiotics?
Not within the Gazette app. Patty might be able to speak more to the plans that exist post this project, but the feedback loop is at the moment within the Gazette app is very much between providing feedback to the professionals entering the prescription decisions into the app, not to the patients. Absolutely.
This app is to inform the decision of the professionals, in the case of surgeons, and the next manage decisions which involve routine in my setting and surgery. The purpose of this app is not to involve patients because it is a decision which functional way, and we need to follow guidelines, so it would be inappropriate to use such an app for patients. However, there's massive scope and need for data citizens as well, so
Yeah,
that's
that's
a
a
really
good
high
point.
added contribute to this program as well.
Thank you. Any other questions? It's very interesting, the behavior change as a model, as a underpinning framework for these new developments. Thank you. So, we move to the next speaker. So, welcome to Susan. For our next speaker, talking about gamified AMR stewardship decision support app. Okay.
Yes, so my name is Susanne Lüdke. I'm a public health specialist working at the public health agency in Germany, where I'm leading the infectious disease department or infection control department. And I was involved in the GAN when I did my master's in infection control at SHTM, and then I joined Patty in doing my master thesis on the GAN. So I'm going to talk about the results that we had when we evaluated the gas. Guys, trying to leave. I'm using for delay. Okay. Okay, so we heard already that antimicrobial resistance is a very big problem in the world. According to the CDC, there are about 2 million people get infected each year, and 23,000 die at least secondary to multi-drug resistant organisms that cannot be treated because there are no further antibiotics left. And according, that was also already in Patty's slide, the WHO by 2050 we will have 10 million deaths due to infections with multi-drug resistant organisms. And it will cost the global economy of over $100 trillion. So why did we choose surgical site infections? Surgical site infections are associated with prolonged hospital stay, with readmissions, increased cost, morbidity, and mortality. Surgeons don't want that, obviously. Antibiotics are getting prescribed in the whole hospital, also especially in intensive care units, on the internal medicine ward, with especially in the oncology, hematology wards, where there are a lot of immunosuppressed patients, where you're especially concerned of multiple infections which you need to treat, and often then you treat with like not only small spectrum antibiotics, you treat with large or broad spectrum antibiotics. However, with the surgeons, we needed a pilot project, so we needed to address a specific group of people where we could also measure it. And so we decided to go with the surgeons, also because surgeons often are very busy, and they want to make sure everything is covered. So I just give the antibiotics. They do this with the surgical antibiotic prophylaxis. Like Patty already said, not everybody needs surgical antibiotic prophylaxis. It depends on the risk of the surgery and on the risk of the patient. But surgical antibiotic prophylaxis is a brief course of antibiotics, which is given immediately before surgery. And sometimes there's, if the surgery lasts very long, another dose. And that was for us, for the AMR, was a very good point where we could see if we can change behavior with the surgeons, because we could define also how long is the antibiotic course, why is the antibiotic given, what kind of antibiotics. So a quick word on antibiotic stewardship programs in the world and in Africa. They're very important. In a lot of countries, they're mandatory by now. At least that there is sort of an oversight of what antibiotics are given. They do help. When there is a team that looks at antibiotic prescribing patterns of the hospital, gives surgeons feedback or medics feedback, then we see that the antibiotic consumption is going down, and that the development of resistant organisms is actually halted. So in low to middle income countries, not only in low to middle income countries, it's also in developed countries, but in low and middle income countries, there's a larger gap of not having antibiotic stewardship programs. And so in Africa, we only have about 15% of the countries have infection prevention control programs. In Nigeria, it's doing a little bit better with nearly 25% of tertiary care hospitals having an established antibiotic stewardship program. So coming to our study, to the results, we had 3 hospitals, as we said already. In total, we had the focus groups. And in the end, we had 20 surgeons who participated in the study. Out of those, were about 50% senior doctors and 50% junior doctors. We had 55% male doctors, and the rest was female doctors. The departments, you can see that ONG, so that's obstetrics and gynecology, they were the ones most heavily involved using the app, and general surgery. And then you had, in general surgery, exactly. So, yeah. So we had in total 343 surgeries that were entered into the app, which on a user surgeon level ranged from 1 to 87 surgeries, in a median of 9 surgeries for surgeons. The recommendations made for the surgeons by the application. So just to go one time more through the app for your understanding, prompted the surgeon after the initial choice to either proceed with their choice or to reconsider their choice. The first decision made by surgeon was classifying the surgical procedure as low or high risk. The second decision was to determine if a surgical antibiotic prophylaxis was needed or not. The third decision was if what type of antibiotic they were choosing, and the fourth decision was about the duration of the antibiotic. So that was basically our results. And the surgery risk, you can see we had we gave either a point that was C, which is choice within the guidelines, or N, which was choice outside the guidelines. So surgery risk, you see we had 291 surgeries, which were correctly notified by the surgeons, correctly chosen, and they didn't change their decision after getting feedback from the app. Then we had CN, meaning the first decision was right. They got the feedback from the app saying that was right, and they didn't change it. Then we had NC, first decision was not with the guidelines, was wrong. They got the response from the app that says that's wrong, and 37, meaning 37 surgeries, so 11%, they decided, okay, I'll change it to the correct decision. We had NN, which means the first decision was wrong. They got the feedback and they decided, no, I'm still not doing what you want. I'm continuing with my decision. So we had a significant change with a p-value of 0.01 that showed us that once they got feedback from the app, they actually changed it to the correct decision. The third choice was not significant. However, we can still see they gave the antibiotic yes or no, basically, that's the same choice. And we had correct to non-correct. The choice within the guidelines was, the choice within the guidelines to not within the guidelines changed, but we also had a change within not within the guidelines and then correct within the guidelines. So that was not significant. The subtype is what kind of antibiotics you're choosing. So we had 23 surgeries. So 7% of the surgeons deciding to change their decision to the right antibiotic. So that was significant. And then we had the duration of the antibiotic. And also here we see that in 16% the surgeons first said, no, that's not correct, and then changed it to a correct duration. So that was also significant. This is an overview of the antibiotics that were given. I don't want to go really into this right now, but we can see, for example, that first generation cephalosporin is a very narrow spectrum antibiotic. And we see that the initial recommendation from the app was that the initial choice from the that the initial recommendation from the app was to only give it in one surgery. The initial choice was from the surgeon. We're only giving one. In one surgery, out of all the surgeries, only one surgeon decided I'll give just a first generation cephalosporin. The app, however, told the surgeons in 86 surgeries, you should give us first generation cephalosporin. And in the end, only three surgeons decided to change the decision. So there is still a lot of like room for improvement, but it was like a nice overview on antibiotics. That's the duration. That was one of the points where we also had a big change. In the top, you see no surgical antibiotic prophylaxis was supposed to be given. Initially, only 28 patients, 28 surgeons decided we don't give any antibiotic, and then they changed it to 59. So we had a big increase there. For example, no antibiotic. So in summary, we showed quite a lot of changes. I don't have a lot of time anymore, so I need to wrap up. But we showed that we had a 16% significant change in shortening the antibiotic course after feedback to be in line with the guidelines. Still 25% of antibiotics were prescribed without a clear indication, but also that means 75% were actually prescribed with clear indication, which is good. Surgical patients were prescribed antibiotics for SAP, which were broad in the coverage, which is still a problem. Reasons for not following published guidance or following local practices, as was said before in Caroline Lutz talk, or the patients in line requires prolonged doses. And decision pointed out what antibiotic to use showed a significant 70% change to the physician's decision within the guidelines after this. Thank you very much. I think we don't have more time. So there is a lot of room in improvement. We have we have our panel discussion. I think I'm not only talking about this, but also in other countries, like especially in Germany, where I am right now. Room for improvement, meaning we have, as was said before, we have the problem. There are no guidelines, no national guidelines. There's not enough education of the surgeons or the medics, and there's no antibiotic resistance profiles in those countries. So if I don't have those informations, then automatically I'm not going to follow anything if I don't have it. So you can see just with like the small app, or this, not a small app, it's a big app. So with the small, I mean, we had 20 surgeons with this, they, even with like small informations they got throughout the day, we didn't educate them over hours. We just gave them like a little input, like, hey, this is, you should like not give them those antibiotics. And we still had significant changes to shortening antibiotics. And I think with this, we've had, if this was ramped up, if the education with like with an app that's easy, like a small handheld app, it's easy to use, everybody has access. In Africa, nearly everybody has a phone and has access to this, and so we can make big changes. Any other questions?
It's like shout. It's more an observation. I mean, it's really great, and I suppose the interesting things for me are you've identified those key influential people, particularly medics, that they need to be targeted to encourage uptake. And also, I'd be interested in what the plans are to follow up with this, to see if behaviour change and uptake improves over time. If surgeons are seeing better outcomes for their patients, the decision they're making, if that's okay.
Yeah, Patty just left the room conveniently. I'm not that much involved in the project at the moment. Consa is here, she is involved. She's like, the plan is to start the project at the Whittington, which one? Whittington Hospital. And we also want to kind of see if we can make a distinction between this is a junior doctor, this is a senior doctor, because we have those problems. They were also mentioned before that we don't know if the junior doctors are influenced by the senior doctors, and if we give them the chance to like just decide this for themselves, then we have a better understanding.
Any questions? The antibiotics, this kind of the dose, how people actually understand a lot of different behaviors involved. And it's a conscious thing where say that normal people use prescribe antibiotics. Is based on the competitive practice or it's more kind of habitual?
I think it might be a cultural thing. We know in Europe, for example, in Denmark, or in the northern countries, Scandinavian countries, also there's much less antibiotic use compared to the southern countries, Spain, Portugal, they have much more antibiotic use. But we can see it, for example, in Germany, we can see it in the north, they use more antibiotic than in the east part. I don't know why. Also in the winter, for example, when everybody has a viral disease, everybody says, I need antibiotics. And some doctors, or a lot of doctors say, yeah, okay, but maybe a little bit unsure, could be maybe something bacterial, and then they give it. So, yeah.
So maybe the app can also discover that. Thank you for doing this. Thank you. Yes.
I just wondered if there are any plans to roll this out with primary care rather than facility.
I'm personally thinking about it, but we haven't discussed it yet. But yeah, I spoke to actually a colleague in the US who is a surgeon in like a private practice, and when I listened to his stories about antibiotics he uses, I actually discussed it with him. I'm like, listen, I have this app. Maybe we can like start doing that. So now we haven't formally discussed anything, but yeah, it's definitely an idea.
Suggested. Next speaker is online and response. So you're talking about supporting antimicrobial stewardship in healthcare facilities through the global point reference survey of antibiotics of consumption and resistance.
Yes, thank you very much for inviting me for your 5th anniversary event. I'm very pleased to be with you. My name is Anders Bokten, and I'm based at the Laboratory of Medical Microbiology at the University of Antwerp in Belgium. And as mentioned, I'm going to talk about supporting antimicrobial stewardship in healthcare facilities by the use of the Global Point Reference Survey on antimicrobial consumption and resistance. Oh, I do share my screen. You don't see my screen. Okay, should I let me try again. Okay, I'm sorry. Let me try again. I thought I was sharing. Yeah, okay. Is it better like this?
Yeah.
Yeah, okay, thank you. Letting me know. So let me go straight away to the next slide, what we are talking about. Based at the University of Antwerp, we are offering a standardized surveillance program called the Global Prevalence Survey. And there are three important points there that we offer. It's a way to assess and monitor antimicrobial prescribing, infections, community-acquired infections, healthcare-associated infections, and also resistance worldwide. Of course, you all know we offer the standardized method. It's a point prevalence survey method that gives you a snapshot in time of what antimicrobial prescribing is in an institution, in a hospital. But collecting data alone is not enough, and you need to do something with that data. You have to move forward and link antimicrobial stewardship actions to it. So we do also provide in this way real-time standardized feedback reports with a benchmarking with national data and regional mean prevalence results from those participants also participating to the global PBS. So whenever those participants based in the hospital have participated in the global PBS in its surveillance, they will thereafter, hopefully, when investigating the report, be able to see and discover points where they can work on. For example, in surgical wards or in intensive care units, they discover issues where they can work on and they can set out interventions. And we try to offer really a very easy, simple way to measure antimicrobial prescribing, healthcare-associated infections and resistance, so it will be easy for them to repeat global PBS and in this way measure the effectiveness of these interventions. So these are the aims of the global PBS. We aim to identify the burden. First of all, provide survey performance indicators. So we have a lot of variables included in that survey, quality indicators, to allow participants also to identify targets, quality improvement of antimicrobial prescribing. It will help also the hospitals to assess the burden of healthcare-associated infections and related antimicrobial prescribing. So whenever you have the data, it's aimed to change practice. This is the course all about. It will help to support hospitals to design hospitals' interventions and to promote appropriate use of antimicrobials. And also it helps identifying potential risk factors of healthcare-associated infections, because we also have an additional healthcare-associated infection module where we are more specifically interested in the use of invasive devices. So, and then measure the impact whenever your hospital is able to set up interventions in the hospital, they will be able to assess the effectiveness of those interventions through repeated PBS. And that is actually instrumental in planning and supporting local and national stewardship actions. So what are the methods? Very brief. So we provide a standardized methodology to survey not only inpatients admitted in hospitals, but we recently also launched an outpatient module, just recently during ECMIS 2023. And everything is available on the website, the protocol and the data collection templates. Besides that, we offer also a simple, freely available web-based tool. It's an application for data entry, validation, and feedback reporting. So we really, we have a dedicated team, IT team, to make sure that the data participants enter online, because it's an online web-based application, that there are as less as possible human errors and that we get as much as possible valid data. So you can start working with those data. We collect data, but actually it's like a quality improvement study where you should be able to set stewardship interventions in your hospital or in the future in the outpatient setting. Participation is on a voluntary basis, so there is no remuneration foreseen for hospitals or the institution. All the documents are freely available and also the applications freely available on our website. And also an important point I wanted to touch on is that it fully complies with data confidentiality principles. Not only the way you collect data on patients, but also there is the data confidentiality towards the hospital names. We all know that it can be very sensitive for hospitals to collect antimicrobial use data and resistance data. So we really take care of that very much. And that's also important for the sustainability of the project. And yeah, so the next point also concerning the method, I wanted to share that it is possible to participate as an individual hospital. So any hospital or any institution is free to participate, but also within a network. For example, we have a very big network in the Philippines. They participate with the Ministry of Public Health, and they centralize all the data. And they have the database from all the hospitals, over 60 hospitals participating in their network. And that's very interesting for them towards analysis. They can obtain aggregated results. So that's, I think, also a very nice thing. So the institution, as I can say, builds up an own database. Whenever you repeat the PBS, you have all those data in that database that is then there for the institution or the hospital. So a brief history, how we have grown. I was thinking maybe you're interested, where do we go from? So in 2014, we started with the protocol development and piloted also the global PBS. It is funded by AMR. So they got funding in 2013. And then in 2015, we launched the very first worldwide global PBS. This one is also published. It was conducted in 53 countries and 335 hospitals. In 2016-17, we expanded our network. And then in 2018, on the demand of our participants, we opened 3 surveys a year, so they could repeat the global PBS, the survey within a specific year. In 2018, we introduced the associated infection module, specifically to get more insight in invasive device use and morbidity factors, for example. And then we had a big drop. The COVID pandemic came there, and we saw it a lot in the degree of participation. That there were completely other priorities in the hospitals. So we recovered now the participation degree. Meanwhile, in 2018, we reinforced our team. I started back in 2014, but as we have grown, it became impossible and we needed to reinforce our team. So we reinforced our team in 2018, and also we have now the communication team who is helping us with the development of the website, all kind of communication materials. The IT capacity has been enforced, and we also translated our website in 7 languages on the demand also of our participants. And then in 2022, we started to develop the outpatient module using also the method of a point prevalence survey, which I do believe is quite novel. In the beginning, I thought, yeah, just start it, we will go, but it was a rather tough exercise. And with the network we have, we were able to get, I believe, a nice protocol. And also the tool has been developed, so we launched it also now worldwide now during ECNIC. So when any hospital is also welcome to participate to the novel outpatient module. So this is a whole tragic that I showed to you, but that is really thanks to the voluntary support of the worldwide network, honestly, because we couldn't do that on our own. We got so much expert advice from hospital-based health professionals for protocol development. Many times we get feedback and we really try to take into account of their remarks so we can continuously improve and be of help to the hospitals to have a good surveillance program. Software testing or general comments from any participants, for example, they want to see specific feedback in the feedback report, and we think about how we can integrate that. So we are also bridging research interest between participants and institutions. We find it very enriching, really, the collaborations we see between the participants and us. So because we have a rather large network, this is really very interesting to work with, to share and transfer the knowledge. So I do believe it's the strength of our network that, and of our sustainability of the network, that we are rather transparent in how we work. When you go to our website, you will find nearly all of our documents. So this is the degree of participation up to now in America, South America. I'm not going to list it up, but you can have a look. So up to now, we have over 90 countries who have participating at least once to our survey, with a lot of different institutions and patients in the database. I'm not going to present you the results because, yeah, I was thinking maybe I give you an insight in how our feedback report looks like. This is, for example, our 1-point feedback reports, some slides that I took out. So they are presented in tables, in graphs, and the own hospital results will be plotted against country results, the continent, the hospital type also, because, for example, hospitals find it very interesting to be able to compare themselves. Imagine they are belonging to a tertiary care hospital, that they will be able to compare themselves to other tertiary care hospitals, and also Europe. So a new feature we also launched during ECMID 2023 is the interactive online reporting, and it's provided to every participant. So it's provided through the Global PBS application. It's not public available through our common website. Why we decided to do this? Because we had also a longitudinal feedback report, but because data becomes so big, and the feedback report is programmed using R, statistical software package, and it took such a long time before the participant got the feedback report in his email box. So we thought that this would be a very nice time, and then it's also on demand that you can ask, I want to have the results for this year, this type of award, for example, or for this kind of antimicrobials. Oh, sorry. So this is all the presentations. I'm almost there. So I wanted to show you also one slide on the antimicrobial quality indicators obtained from the global PBS. This is not an exhaustive list, actually, not only the prevalence of antimicrobial use, but also specifically quality indicators such as are local guidelines available, and if they are available, is an antimicrobial prescribed according to the guideline. Is a reason being written in the notes. So this is a list, and maybe I jump here. This is one of my last slides. That I really wanted to show the collaborations we have also with other organizations. Like recently we have a European funding where we work together with the Radboud University Medical Center in Nijmegen in the Netherlands, where we really have a link between global PBS where we collect data, and then the next step, how are we going to help our network towards sustainable stewardship actions. Actually, it's really a data-driven implementation of behavioral antimicrobial stewardship approach. We work also with the Commonwealth, and we have a database here.
Thank you. Thank you.
Okay, thank you. Thank you. I'm happy to take any question.
Yes. So I was a quick question. We are out of time. So, and it's great that this project is collecting data from these acting and then the hospitals locally. And this is like we not just collect data for the sake of data collection, but also have some action. This is where we have been discussing for over a few years how the project like Gaza can actually help the intervention of the hospitals. We want to do something about the data they have collected when using it with the experiments. Do you want to comment how we come back and be able to our meeting?
Yes, when I saw the presentations just now, I was thinking we have to get in touch again to see how we can collaborate. Because truly, it could well be that hospitals, when they see the feedback report and they discover issues in their surgical prophylactic prescribing, for example, but of course, it's a snapshot in time. And by the way, it doesn't give you the details on the dosing and every time or the real duration. So with that app would be very interesting to introduce that. I think we have to talk after this and brainstorm and think together how we can maybe jointly work and offer our institutions, our hospitals, that bit more that you have that we don't have. So that would be really very interesting. Yeah.
Discussing later, and we have more questions and discussions. So the next speaker will be Dr. Abdul Consular Omar from the UCL Division of Infection and Immunity.
Okay, great. My name is Abdul. So I'm based at the Malawi World Trust in Manta, Malawi. And I'll be giving a talk about basically surveillance of the pneumococcus in a community that was exposed to mass drug administration of an antibiotic. So the pneumococcus is a global pathogen. I told there's over 300,000 deaths among young children due to invasive disease. So the pneumococcus is normally can be normally carried by healthy individuals, and carriage is a prerequisite for transmission as well as local and invasive disease. So local disease involves examples are sinusitis and otitis media, infection of the ear. But you also get invasive disease that includes bacteremia, sepsis, and pneumonia. So the pneumococcus is classified using multiple approaches. So serotype is based on its outer capsule. So there are over 100 immunogenic capsules. So vaccines are based off these capsules. So the vaccine we use here in Malawi is PCV13. So this covers against 13 out of the over 100 serotypes that are present. Sequence typing is based on 7 housekeeping genes. So this helps to define clonal population. So whether there's a particular outbreak of a certain clone, sequence typing is the approach. But to look at the lineages at a global perspective, there's a global sequence clustering approach. So this takes into account the entire bacterial genome. So you're able to study similar lineages across the world. So the pneumococcus has become a serious antimicrobial resistance threat. So this has been established by the CDC as well as the WHO. And one of the antibiotics that has been indicated are microlide antibiotics. These are carried on mobile genetic elements. So these are basically, they can basically jump from one bacterium to another. So a particular type of element is integrated conjugated element or ICE element. So these elements are present in the bacterial genome. They can circularize and they can transfer to a susceptible bacterium, and then they integrate in the genome, and all the descendants of those of that bacterium will have this element. So you can imagine in a community where you have macrolide selective pressure, it can allow the bacteria like this purple one up here to expand, and you have this as one of the dominant lineages circulating carriage. But you also increase the reservoir of these lineages that have these elements. So bringing into the picture macrolide mass drug administration. Macrolide MDA is used for trachoma control. So children are given macrolide antibiotics at a specific time of the year. But there was a particular study published in the New England Journal of Medicine that was basically plus a randomized trial involving countries including Malawi, Niger, and Tanzania. And they gave mass azithromycin to children four times twice yearly between 2014 to about 2018. The results from this was that in Niger only, there was a 13.5 lower all-cause mortality in the treatment arm compared to the placebo arm. But then this does have implications on other bacterial species, looking at AMR. So immediately after this study, in the short term and in the medium term, they saw that there was an increase in resistance amongst carried streptococcal pneumoniae. So our question was whether this MDA results in long-term macrolide resistance and fixation of the elements that carry these genes. So our study was conducted in Mangochi district. So for the purposes of this talk, I'll refer to this as the rural site. So we have an archive of isolates that were sampled in 2015 at baseline. 2017, this is towards the end of the trial. And then we did a prospective carried study in the placebo and the treatment arms about 3.5, 4 years after. So this is what we defined as the long term. So we sequenced the isolates, looked at the population structure. So this is the sequence type, serotype, and the lineage. We looked at AMR genes and also identified the element. So looking at macrolide prevalence, on the y-axis is the percentage of resistant strains. At the bottom are the cohort, so that is the azithromycin and the placebo. So you can see that from on the azithromycin side, there is a marked increase in macrolide resistance across the year, even in 2021 when the intervention was stopped. So you can see that the resistance has not gone back to the baseline levels of 2015. But we also noticed a similar increase in the placebo groups as well. So we are speculating that there's possible movement or dissemination of lineages in the azithromycin going to the placebo over time. But also Mangochi is an area where there is a bit of trachoma, so there would also likely be some degree of macrolide usage in the placebo groups as well. So we compared these rates to that of an urban site. So this is hundreds of kilometers away from our rural site. And you can see that these rates are much farthest than those that are seen in the rural side. So we can see that the effect of the mass drug administration on resistance persists in the long term. So we looked at the lineages over time. So one of the lineages that we highlighted was lineage 5, and this is what increased over time. So this is the 2015, 2017, and 2021. And then we have the placebo followed by the azithromycin arm. So you can see this increase. And the color is showing the different colors in green showing that the macrolide resistance gene was present, and the reddish pink is showing that the gene was present and it was on an element. So you can see that lineage 5 is an important lineage. And when we expand on this, we can see the sequence So lineage 5 was strongly associated with this 172 sequence type and was linked to a serotype 15A. So this 15A is not covered by the vaccine that we use. But you can see that it expanded post MDA, and similarly at the serotype 35B, a sequence type 10599. So we can see that these lineages expanded and they're associated with resistance and isolate. So lastly, I won't go into this in too much detail. This is a phylogenetic tree showing the relationship of all the isolates we analyzed. And you can see that this lineage 5, specifically here is the, where you can see in the lighter red is the serotype 15A, the serotype that I previously highlighted. So what we had wanted to find out here was whether the element that we identified in the serotype 15A sequence type 172 was similar to other lineages in our data set. So when we looked at the similarities, we did see that this lineage that had expanded was sharing identical elements to a serotype 6A. So this is a serotype that is covered by the vaccine. So this is suggesting that there is direct or indirect transfer of these elements. So I think either way that you look at it, I think it is important whether a vaccine type shared it with the non-vaccine type that has now disseminated into the population, or whether it's vice versa. So we're still looking into this in terms of how significant and how much sharing there is in the data set. So to conclude, we can see that macrolide resistance prevalence has not reverted to pre-mass drug administration levels. And the lineages that have expanded, and the specific lineages that have expanded post-NDA, this may be due to antibiotic selection, but it may also be due to selective pressure from the vaccine. But when we did compare this to the Blantyre side with the urban side, you can see a very distinct difference in the prevalence. So most likely the lineages are different. And we can also see that the sharing of these identical elements does suggest direct or indirect horizontal acquisition, which may have broader implications in the larger data set. So overall, mass drug administration has a long-lasting effect on pneumococcal AMR. And I think there is a lot of caution that needs to be taken, particularly with some of these public health interventions involving mass drug administration. So thank you. These are the individuals I'd like to acknowledge.
Thank you, Apu. Over time, so can I just kind of invite one question for this talk? Anybody want to ask anything? Yeah. You no? Any comments? If not, we're moving to the next section. Thank you, Apu.
Thank you.
The second part of this section, and hopefully, if you don't mind, I will try to keep it short and we don't compromise our coffee break. So this section is about UCL grand challenges and GC exhibition. The first speaker is James Paskin, talking about the evolution of grand challenges.
Thank you, Marina. So along with me, Marina is 2/3 of the Grand Challenges team. We'll do my best. I've only got 5 minutes and no questions, but I'm going to be over in the South Cloister standing next to all the wonderful GC exhibition we managed to get, that we managed to get the UCL exhibitions team to help us build, which is just a brilliant overview of some of the work that's been done recently on the Grand Challenges. So I probably won't cover everything, but the very ambitious title is Evolving the Grand Challenge, the history of GCTT going forward, which there's more than I can cover in 5 minutes. Slide. So the grand challenges came from a commitment from the university that there was something that a large research intensive university like UCL could do to look at the problems, the really big global problems. So the things that I think everybody in IIDR will be familiar with is it's trying to make the world a better place through research and working with people on the ground. So we started on the cross-disciplinary piece, really trying to harness the cross-disciplinary power of the university. Increasingly, as we've been working, we've realised that cross-boundary piece of working with people in different sectors is just as important. So one of our aims is to increase mutual knowledge and engagement, but also to work in co-design and co-production, use co-design and co-production approaches so that we can get solutions that really work. And to do that, we need to work with the experts, who are all the people here in this room and all the people spread across the university. Have the next slide, please. So again, probably saying some of the same things again. One of the key insights is, I'm going to say this again, but solutions don't come from a single field. We've always had this reliance on cross-disciplinary rather than interdisciplinarity, and part of that is this idea of people with T-shaped skills. They've got very thick trunks. They understand their disciplines, but they're also very happy to branch out and work with people from across the university. And as I say, working beyond the university as well. So we are part of research, innovation, and global engagement. So not only do we have our own team in the research piece, but also with the innovation teams and the people in global engagement. This is a rather confusing slide, which just shows the results of one of our recent funding schemes. Down here, we've got UCL lead faculties. And they either work with partners within UCL, and you can see those in the kind of orange there, but we've also, as I say, we've been encouraging people more and more to work with people outside. So the blue links here are people within UCL linking to places outside. Next slide. Oh, yeah. You will be able to see the Grand Challenges exhibition for a limited time only in the South Cloisters. So we had a great launch, a very well attended launch here. I like this picture because it really shows how many people were milling around and trying to get a look. You'll see behind there, there's the Neo Tree exhibition with Liam and Olivia chatting to each other in front of it. I forgot to put mantra on the slide, so I beg your forgiveness. I'm really sorry. But Neo Tree was one of our star stories. It was one of the things that we knew we had to, when the exhibitions team came and said, what do you want to talk about? Neo Tree was one of the ones we wanted to have up there, as was our link with IRDR. The Grand Challenges was linked to IRDR from the very early days. So Ian Scott, you see there, was closely involved in the beginning, so helping IRDR get set up. So he's kind of a godfather of IRDR. So next slide. Oh yeah. So I promise I talk about history. GCTC I haven't really covered, but I can talk a little bit about the future. So we currently have 6 grand challenge areas. These are all being replaced. So the strategic plan has completely changed the way we're thinking about the grand challenges. We're extending our scope. So we'd be very much in the research space. We're going to be moving more into the operations. So trying to bring the insights from grand challenges work into the way the universities run. And this one really scares me because I know nothing about it. Education, how we can use grand challenges insights to teach people in the university. And also we're going to have identified academic leads who will be paid by the grand challenges to lead these new areas. Next slide. Fantastic, thank you. So here we have the challenge areas we already have. And they're all being transitioned. So over the next 5 years, we will move completely from these into these new challenges. So next year we'll see climate crisis, mental health and well-being coming, replacing services and human well-being. Transformative technology will be replaced by data empowered societies. At least that's the plan so far. But all of these, I think, all of the new areas certainly have got can come into the work of IDR, and certainly and dPHE I think has definitely got a part to play in solving a lot of these. So I think I'm going to have to wrap up. And if you want to ask me some questions about the grand challenges, I will be milling around drinking coffee. So there might be another slide with just our contact details. Thank you.
Thank you. So case study for the grand challenges is the venture. So, how do you talk about that?
Oh, sorry, it's me again. So we're gonna be the showcasing one of the project, which is the star project in the exhibition called Mantra. Just very briefly, I have the Mantra on my phone, so if you want to come to talk to me, you can even have a play with on Mantra on the phone. So this is a game which is based in Nepal, so a tiny country in the Himalayan region. And our purpose in this NERD-funded project was to develop an app for the women who live in rural part of Nepal, who are living in a very remote part. They have to walk, some of them 2 hours to meet up in those women sessions in the central village where we did this project. And we have developed a game which was aimed at people with low literacy or even illiterate who have never used their smartphone before in many cases. And we have to develop something which they would grasp the knowledge and gain very quickly to improve their confidence about maternal and neonatal health through the game and empower their decision making to know when they should be using and when they shouldn't be using healthcare providers. So as I said, the Mantra has got 3 different parts: maternal health, neonatal health, and also geohazards, which are very common reason for death in especially around the earthquake, and more people died as a result of neohazards than during the actual earthquake. So as some of the people have not actually used a smartphone before, we have to develop a little tutorial of touch and play. So they have this picture of the baby in the arm of the mother. They have to move the baby back to the arm to actually learn how to operate the smartphone. So really challenging, but really rewarding project to work with people who haven't used the smartphone before. Again, I got just a pictograms. We work with very gifted artists and the local people to understand what these images would mean to them, to their culture, to be able to depict the common conditions for maternal neonatal health. And they were not getting points in points, they were getting points as a little leaves on this flower you can see on the side, because nothing could be done in numbers and letters to address the illiteracy issue. And this is a very busy slide to show that we have achieved a behavior knowledge change around the 3 different modules, especially around some of the objectives highlighted on the website. And we also got 2 projects, 2 awards for this project. It was a Finite Diversity Project of the Year, and my colleague Caroline Wood and I got a Best Partnership Award for Mantra. And some publications, but also be interested in the actual game. Come and see the Grand Challenges show, and you can see the game. Thank you.
Dr. Emma Wilson talk about the usuaries.
So good afternoon. I'm so delighted to hear that Neotree was a star story at the Grand Challenges exhibition. That's wonderful news. So yes, my name is Dr. Emma Wilson. I'm a senior research fellow at the Institute of Child Health, and I'm just going to give you a very quick overview of Neotree on behalf of the Neotree team. So the problem we face is that every year 2.4 million babies die within the first month of their lives, and most of these deaths occur in low resource settings. And we also know that about 30% can be prevented through improving postnatal care and particularly adherence to evidence-based guidance. So our solution is Neotree, which is an open source data capture and visualization tool alongside education, clinical decision support, and quality improvement. So kind of all singing all done. And we're currently implementing in 3 tertiary settings, so 2 hospitals in Zimbabwe and 1 in Malawi. And I'm delighted to say we recently got some funding from the Foreign Commonwealth Development Office to start piloting that sort of lower level facilities, so a community hospital and a primary care site in Malawi. So that's new work that we're involved in. So just to give you a brief overview of the sort of key features of Neotree. So the first thing are electronic healthcare records and data visualization. So data is captured on admission and discharge, as well as laboratory results for every admitted baby to these hospital facilities. So that allows clinicians to track case-specific mortality rates, as well as sort of performance against key quality improvement metrics that they may have decided on in their particular facility. And in addition, we have clinical and civil support, education and training, and these are based on evidence-based algorithms. And finally, Neotree is the back end of Neotree. There's ease of configurability. So this means that the content and the guidelines can be easily adapted to sort of local guidelines and also sort of the equipment and resource needs of those particular settings. So I mentioned the primary care facilities that we're going to adapt to. So obviously the equipment and the sort of skills level there is very different. So the back end we can sort of adapt guidelines for the back end, the Neotree. And then finally, data linkage. So Neotree allows data linkage to national aggregate databases. So in Malawi, we've shown proof of concept to link into the DHIS version 2. And in Zimbabwe, we have we've really completed work for push functionality to the national electronic healthcare records. That's in the US system. So that's very exciting, because hopefully quite soon Neotree will be able to export directly into the Zimbabwe EHR. And just to mention some ongoing work that's been funded by UCL Grand Challenges. So colleagues are using machine learning methods to refine a predictive model for the diagnosis of neonatal sepsis. And what they found is machine learning techniques have performed better than logistic regression models, and external validation and refinement is ongoing. And then also a project that's been led by my colleague, Dr. Nusrat Khan and Professor Tim Colburn, to see how we can better use Neotree data to monitor and sort of measure key quality of care metrics. And actually, we've just come back from Zimbabwe and Malawi, where we met with Ministry of Health officials and also local clinicians on the ground to try and decide what would be the key metrics, both at the local ward level, but also the national level, that we could use the data to monitor. And I think the great thing about Neotree data is that it's in real time, so that we can have real up-to-date sort of idea of how they're performing against these metrics. And of course, next step. So we have to, an intervention is never fully cooked, as it were. We're continuing to optimize the functionality, ongoing research and analysis, so refinement, optimization of the sets of algorithm, and implementation evaluation research. So we're seeking funding to do a large-scale evaluation to hopefully show the effectiveness in case fatality rates. And yes, we also have an ongoing program of public engagement where we're working with mothers and caregivers to ensure that care pathways in the facilities that we're working with are family-centred. And yes, thank you to all our partners and funders. And I'll be around, I think, later if anyone has any questions. Thanks.
Thank you. This section is called good bugs and bad bugs. So the next few short talk will about the good bugs, I guess. The first one is the next one was Catherine talking about cheese.
Hi, I'm Catherine. The work that I'm going to show you today has been funded by Grand Challenges Transformative Technology. And I've taken a very familiar path through my PhD. I recently finished. That's what it looked like. And what I did was I quantified dietary change for the last 30,000 years. And of course, one of our largest shifts in diet has been the inclusion of milk from other animals, exogenous milks in our diet. Not all populations, but some populations. And of course, this is something that we've adapted to biologically. So we have 5 genetic adaptations to this change in diet. But of course, we also adapted culturally in the form of making cheese. So I'm going to show you some of my work on cheese today. So we know that the oldest evidence we have for milk in human diets comes from the Fertile Crescent about 9,000 years ago. Earliest evidence we have in Europe is from Poland. We have 2 sites where we've got milk lipids embedded in those potsherds. The earliest cheese making is from Croatia, shown in the middle. We also have this lovely female mummy from China from 3,800 years ago. And she's buried with a kefir cheese necklace. We've done proteomics on the milk that's in the substance, and so it's been confirmed that it is it's a dairy product, kefir. So closer to home, we have Cheddar Gorge, which that was formed millions of years ago in Somerset. Cheddar Man actually didn't drink milk. Cheddar Man is pre-Neolithic. The Neolithic in Britain is about 6,000 years ago. Cheddar Man is 10,000 years old, but the genomics and a lot of the analyses were done in our lab here at UCL. And then Cheddar Gorge today is made for what we now are storing cheeses in the gorge. So you can buy cheddar cheese. Cheddar, it gives its name to our most famous cheese. So I want to look more at this cultural innovation. So what I did is I teamed up with a cheesemaker in Cumbria working with sheep's milk. And Neil's Yard provided free transport for all of my samples to London. And I was working with a colleague at London School of Hygiene and another colleague here at UCL. And we did all of our DNA extractions in our Darwin labs and then 16S sequencing. So we've done next generation sequencing on the samples. And what we found in some ways was what we expected. We expected higher microbial diversity in the raw milk, and we've got samples raw milk from indoor reared and outdoor reared sheep. And then we were able to get down to the species level. We developed our own pipelines to look at the microbial diversity in milk and starter culture and cheese. And I think this is where it gets really interesting. So here, these are my 3 examples of indoor reared milk from indoor reared sheep. And what you can see is that from handling the bedding and handling the animals, you can see the staph hominis, so staph from the hands of the farmhand, is transferring into the milk. And what you can see in the outdoor reared sheep is a much higher microbial diversity. And what I find really interesting about this is that if you ask any cheesemaker, they always add less starter culture to those outdoor reared milks. And this is starting to explain why. And the other really interesting thing that we found was the Lactococcus lactis, which is the main bacterial component in the starter culture, completely overwhelms and outcompetes any of those microbial diversities in the raw milk. So what I'd like to give you just a few takeaway messages from today is that we've been able to confirm through cheese genomics that the microbial diversity is higher in the raw milks and higher in the outdoor milk than in the indoor reared milk. The starter culture is almost acting like a pasteurization process, not by heat, but by microbial competition, and it outcompetes any strains that you wouldn't want to be consuming live in your cheese. But I think what this really does is it shows us that by using modern technologies, we can really start to understand and pick apart these embedded technologies within our traditional food processes. And tonight, if you'd like to try any of our cheeses, I've brought samples for you to try. And I'd just like to thank the team and Transformative Technologies for funding this work. Thank you.
The cheese is really tasty, so stay at home. And the last speaker of the section, Elena, will talk about fermentation food. I need to take part in my name is Jan Godwin. I'm vice for fermenting skills and also health. And I'm here to represent the bugs. We are the shepherds microbes in our field, which means that there's only 60 educators, producers, nutritionists, scientists in our field who are there to protect the traditional ways while using microbes to alter food and create novel foods as well. So what is food fermentation? So this is obviously a transformative action of microbes that transforms food from one form into another, and obviously this has been used way before we invented pottery. But since the moment we started using pottery, we have over 10,000 years, we have evidence to show that humans have been fermenting foods. What we talk about when it comes to fermentation, we talk about raw fermentation, so we're using microbes that are naturally present, whether in soil or in products or in a particular terroir, without adding starters to feeds. And so obviously with stewardship preserved, we find the science behind fermentation, we started getting more interested in microbial fermentation and trying to understand the food technology behind it. So people around the world fermented throughout the ages. You can find it in Inuit people, you can find it in the Balkans, you can find it in Asia, you can find it in any culture around the world. Even here, when people say, well, we don't ferment in the UK. Yes, we have cider, and we have cheese, and we have dairy fermentation. You can find examples of it absolutely everywhere. That little chimney over there, and this is the traditional Chinese fermentation vessel, and this is a rice wine. And the chili over there on top of there is supposed to ward off evil spirits as well as be antimicrobial and prevent some of the wild beasts of getting into the vessel. Obviously, so many cultures have consumed fermented foods throughout decades and centuries. But only recently has the scientific community started investigating from fermented foods. And so one of the highlights, one of the studies that I would like to highlight is the Stanford School of Medicine one that looked at nutritional habits such as diet changes that can increase microbial diversity as well as reduce inflammation markers. So there's the study down link if you want to link, I can also email it. We are very interested as traditional fermenters and what's happening in the precision fermentation community. Obviously, when I ferment at home, for example, when I teach somebody or I travel and carry my cultures with me, I use and rely on wild microbes. But precision fermentation has been with us for over 30 years, 40 years, 50 years. Obviously, you know, that's the rennet, vegetarian rennet, that precision fermentation has many, and is used 90%, 95% in cheese making nowadays, but also insulin, and precision fermentation is responsible for that. So it's really interesting how precision fermentation is moving into the food sector and how it can impact creation of novel products using microbes. There is a lot of space for different fermentation methods still to be said. There's a lot of funding going into science community as well as food production community and a lot of startups looking at microbial food fermentation and how they can work together. It is what Catherine was saying just a moment ago, what's happening in the TL, the state of the genomics, you can see is happening in other universities across Europe and across the world. And the European Union has funded massive research, inviting science and technology experts to come together with traditional makers to look at fermented foods, what they mean for our health and what that means for sustainable food source for everybody. Thank you.
Speakers, including the online speakers, and we are coming to the end of this session.
I just want to say that we have sample to taste, but you have to stay to the end. Now we have the coffee break, and everybody can interact with each other and have a short conversation. See you later.